Good afternoon, everyone. First of all, I would like to thank the College of Rheumatology and Rehabilitation for giving me this wonderful opportunity to present in this forum. So to begin with, beyond the canker sore, Behçet's disease is my topic today. So this would be my outline. So going to the case history, my patient, Mr. B, who was a 26-year-old male from Hatton, who is an army officer working in Jaffna, presented to us with a history of fever for 1 month duration in the background of recurrent oral ulcers. So fever was mild fever around 100 degrees once a day, which responded to paracetamol. However, the recurrent oral ulcers was painful, distributed in his palatal area and buccal mucosa, and it was limiting his oral intake due to pain. He was referred to us from the army hospital and sent for opinion. At this point, he did not complain of any respiratory symptoms like cough, shortness of breath, or sputum production. Did not have any dysuria, increased frequency, hematuria, or frothy urine. He did not complain of any abdominal pain, nausea, vomiting, or altered bowel habits. And also, he did not give a history of alopecia, rashes, photosensitivity, or joint pains at this point. And there was no other features suggestive of any connective tissue disorders. He denied a history of genital ulcers and denied any history of sexual promiscuity, IV drug abuse, or blood transfusion. And also, he did not give any history of asthma, sinusitis, or features of peripheral neuropathy. Going into his past medical history, in 2025 March, which is 4 months prior to his presentation, there was a history where he was managed for right side pyelonephritis when he presented with right-sided abdominal pain and found to have microscopic hematuria and a mild increase in the serum creatinine. So at this point, he was managed for a right side pyelonephritis secondary to a possible renal stolls or stricture, and right side JJ stenting was done. However, serum creatinine had returned to normal. However, imaging including ultrasound abdomen, NCCT KUB, and later on CECT abdomen were normal. However, during the same admission, he was also managed for a right side upper limb thrombophlebitis. He had a long-term rash in his bilateral lobes, which was managed as lichen planus. His past surgical history was allergy history. He did not have any allergies for food, drugs, or plasters. Family history was not significant. And he was an army officer working in Jaffna, unmarried, and he is an occasional smoker as well as alcohol user. Going into his examination, his BMI was around 23 kilograms per square meter. He was afebrile. He was not pale or icteric. There was no lymphadenopathy. In the lower limb, there was this rash suggestive of lichen planus. And there were several oral ulcers distributed mainly on the soft palate as well as the buccal mucosa. And he did not have any genital ulcers during this visit. All other system examination were normal. So this was the large ulcer in his soft palate, and he had multiple other small ulcers in his buccal mucosa as well. So going into his investigations, his full blood count was more or less normal, and ESR was 32, mildly elevated. CRP was normal. Chest X-ray did not show any abnormality. 2D echo was normal. Urine full report, there were 1 to 2 pus cells with occasional red cells, and albumin was trace, but the UPCR was normal. ANA had been done, and the results was pending, and they had also done P-ANCA and C-ANCA also, where they found to have P-ANCA positivity. TB screening, HIV antibody were negative, and hepatitis B/C screening also were negative. So at this point, we had several differential diagnoses. In a young male coming with oral ulcers which were painful, we thought of Behçet's disease. And then inflammatory bowel disease, Crohn's where oral ulcers are common, and we also thought of ulcerative colitis because there was association with P and K positivity with ulcerative colitis. Then SLE and K vasculitis and malignancy also were our differential diagnosis. So our plan was to trace the NA report, and we suggested oral ulcer biopsy. We got a dermatology opinion and pathology test and biopsy and plan to do a HLA-B51 as well. So we got down the patient in 2 weeks for the review. At that point, he had persistent on and off fever, and there were new oral ulcers as well. At this point, he complained of multiple joint pains involving bilateral shoulders, wrist, ankles, and small joints of the hand, which were inflammatory in type. At this point, during repeated questioning, he revealed a history of genital ulcers, which was 4 months ago, which had lasted for a week and resolved spontaneously. And also, during this review, he also had a new skin rash, which was itchy erythematous, which was acneiform in nature over the chest and abdomen, and we also arranged a skin biopsy at this stage. Other biopsies were not yet available. So this was his rash. So at this point, a NA report was available, which was negative, and the pathology test, which was done earlier, it was also negative. We were awaiting the histology. Other investigations were more or less same. At this point, because of the arthritis and the rash in the background of oral ulcers, our main differential was Behçet's. We started the patient on oral prednisolone 30 milligrams. And in his next review, in 2 weeks following starting steroids, the fever had settled, but there was no response of oral ulcers. There were new ulcers reappearing, and he had significant difficulty in swallowing and loss of weight. HLA-B51 report, we got it, and it was negative. So at this point, we were thinking whether our diagnosis was correct, whether it's Behçet's or not. However, we thought of tapering the steroids and then to trace all the biopsies. So he had significant ulcers. So during the next review, when he was on again prednisolone 10 milligrams, the fever had reappeared, and there were new oral ulcers, as well as the multiple joint pains also had reappeared. He complained of a mild eye discomfort. We referred to the ophthalmologist, but there were no features of uveitis. Again, we were thinking whether we are under-treating Behçet's or whether there is any other, we have to think of any other differentials at this moment. However, at this moment, he did not have any other features of GI symptoms. At this point, we got the biopsy from the oral ulcer, which showed the ulcer bed contained exuberant granulation tissue, which associated with dense mixed inflammatory cell infiltrate, which was consistent with a chronic ulceration. So at this point, we were able to somewhat exclude malignancy. And then the pathology test biopsy came as the conclusion was intraluminal and perivascular neutrophilic infiltration was noted, but characteristic neutrophilic vasculitis was not present. However, in the background history, even the intraluminal and perivascular neutrophilic infiltration, we took it as a positive pathology. So the punch biopsy from the abdominal wall also did not show a definitive vasculitis, but there were superficial perivascular inflammatory cells with occasional eosinophils. At this point, during this review, he came up with a new symptom where he mentioned the venipuncture sites, there were ulceration as well as small scratches over the skin showed a reaction which was dermographism. So this confirmed the possible pathology phenomenon. So we confirmed, clinically diagnosed this as Behçet's, and because the symptoms were very much disabling for him, we gave IV methylprednisolone 500 mg 3 pulses followed by oral prednisolone and started him on colchicine and local application of tacrolimus for oral ulcers. Following this, the rash settled, fever subsided, the frequency of oral ulcers reduced. Then we added methotrexate as a steroid sparing agent, and later we had to change it to azathioprine due to mild transaminitis. During review for the next review, we found that there were recurrence of oral ulcers while tapering the steroids. And at this point, due to the resistant recurrent oral ulcers, we had to treat him with IV infliximab. So the last review, the ulcers were resolving, there were no joint pains, the fever had subsided, and we are continuing infliximab and tapering doses of oral prednisolone with colchicine, and we are continuing azathioprine and local application for tacrolimus. This is how we managed the recurrent oral ulcers in this patient with Behçet's. So moving to my discussion, Behçet's disease. Hulusi Behçet, who was a Turkish dermatologist, is he's the person who first described Behçet's disease in 1937 as a triple symptom complex with mouth ulcers, genital ulcers, and recurrent iritis. So Behçet's disease is characterized by recurrent oral aphtha and any of the several systemic manifestations like genital aphtha, ocular disease, skin lesions, GI involvement, neurological disease, vascular disease, and arthritis. So the most clinical manifestation of Behçet's are believed to be due to vasculitis. Moving to epidemiology, typically Behçet's affects young adults of 20 to 40 years of age, and it's more severe in young male patients from Middle or Far East Asia. It's also referred the Silk Route disease as it's prevalent in the Mediterranean basin, Middle Eastern and Far East Asian countries. Most cases are sporadic, and they have described genetic anticipation as well, and males are commonly affected. Moving to etiology and pathogenesis, actually the underlying cause is unknown. Autoimmune as well as autoinflammatory features have been described, and genetic influences including HLA B51 as well as some non-HLA genes have been described in the mechanism of the disease. Also, altered host bacteria and bacterial responses, altered innate immune function, and altered population of hematopoietic cells and associated cytokines, and the presence of immune complexes and autoantibodies, vascular endothelial activation and hypercoagulability, neutrophil activation, epigenetic alterations, these all contribute in the mechanism of this disease, which is a Behçet's is considered a mixed pattern disease where there is autoinflammatory as well as autoimmunity, as well as the involvement of innate as well as the adaptive immune system. So there is an association of Behçet's with HLA-B51. So the unique geographic distribution of Behçet's disease suggests that there is involvement of both genetic and a common environmental factor in the disease in endemic regions. However, HLA-B51 positivity in general population is higher in these regions compared with geographies where Behçet syndrome is not endemic. The frequency of HLA-B51 has been reported around 50 to 80% in endemic geographies. So, despite the close association of HLA-B51 with Behçet syndrome, genetic markers are not necessarily helpful in diagnosing Behçet syndrome. Moving to the pathology, the histology frequently reveals a vasculitis. The classic Behçet's lesions is necrotizing leucoclastic obliterative perivasculitis and venous thrombosis with lymphocytic infiltration of capillaries, veins and arteries. Cellular infiltration is often seen in a perivascular distribution with neutrophils, CD4 T lymphocytes. And when a frank leucoclastic vasculitis is present, endothelial swelling, extravasation of erythrocytes, and fibroid necrosis of the blood vessels can be seen. And the other important thing is the thrombosis. So these are some slides showing dense neutrophil infiltrates around blood vessels and a thrombus with lymphocytic infiltrate in a patient with superficial thrombophlebitis. So moving to clinical manifestations, it's a multi-system disease. So the commonest clinical manifestation, oral ulceration. Most but not all patients initially manifest with recurrent oral aphthous ulceration, which are more extensive and usually multiple. They are very much painful and they have well-defined borders with white-yellow necrotic base and may have surrounding erythema. So there are minor ulcers defined where the diameter is 1 centimeter and more than 1 centimeter is defined as major ulcers. Major ulcers tend to scar. The outer part of the lip is usually not involved. So these are some pictures showing ulcers. So urogenital lesions is more specific for Behçet syndrome and occurs in about 75 or more patients in Behçet's. However, they appear similar to oral aphthous but are usually painful. They are more commonly found on scrotum in men and vulva in women. Recurrence is typically less frequent than oral ulceration. Scar formation is frequent in genital lesions. Epididymitis, salpingitis, varicocele, and other genitourinary inflammatory conditions also can occur. Rarely, it can also cause urological complications like urethral strictures. We also were wondering whether our patient who underwent JJ stenting for an obstruction, whether he also had urethral strictures. Cutaneous lesions occur over 75% of patients with Behçet's, which include acneiform lesions, papulo-vesicular pustular eruptions, pseudofolliculitis, nodules, erythema nodosum, superficial thrombophlebitis. They can also get pyoderma gangrenosum type lesions, erythema multiforme like lesions, and palpable purpura. So these are some pictures, papulo-pustular rash and pustules. They can present with erythema nodosum. So pathergy. Pathergy is an important test in the diagnosis of Behçet's. So it is an erythematous papulo-pustular response to local injury and defined as a pustule-like lesion or papule that appears 48 hours after a skin prick by a 20 gauge needle. Although the likelihood of a positive pathergy test has decreased over time, the specificity of the test remains relatively high. The other thing is the dermographism, which we also saw in our patient, is a response to light scratching of the skin, which also may be present in some patients. So the vascular pathology-like response, where following vascular procedures, if the patient gets a pathology-like response, it can result in phlebitis or even aneurysms. And ocular disease occurs in about 25 to 75% of patients. Male patients are more likely to get eye disease, and they happen to be worse, have a worse visual outcome even with treatment. They can get anterior posterior uveitis and can get complicated with hypopyon. Again, neurological disease is more frequent in males. Can be parenchymal or non-parenchymal. Parenchymal diseases could involve the brainstem, multifocal involving brainstem, cerebral or spinal cord, can occur as myelopathy, cerebral disease, or optic neuropathy. MRI can help in detecting these lesions. So non-parenchymal diseases involving the neurology, they can have cerebral venous thrombosis, intracranial hypertension syndrome, acute meningeal syndrome, strokes due to arterial thrombosis, dissection, and aneurysms. So vascular disease is most clinical manifestations of the Behçet's are believed to be due to vascular involvement, vasculitis. So it involves blood vessels of all three sizes, small, medium, and large, and both arterial and venous circulation as well. Vascular disease is also more common in men. Arterial disease is usually commonly affects small vessels, whereas venous diseases result in venous thrombosis is common than arterial involvement, and usually it's an early feature of Behçet's. Venous diseases can present as deep vein thrombosis, subcutaneous thrombophlebitis, SVC obstruction, IVC occlusion, cerebral sinus thrombosis, and Budd-Chiari syndrome. They also can rarely present with arterial diseases involving pulmonary arterial occlusion or aneurysms, aortic aneurysms, and extremity arterial occlusion or aneurysms. Arthritis in Behçet's disease, usually they are non-erosive, asymmetric, usually non-deforming, most commonly affects the medium and large joints including knee, ankle, and wrists. Inflammation is evident on synovial fluid and biopsies. Renal disease is less frequent and less severe comparing with other vasculitis. Patient can present with proteinuria, hematuria, and mild renal impairment, and rarely can progress to kidney failure. Cardiac diseases are also rare, can present with pericarditis, myocarditis, coronary arteritis with MI or without MI, coronary artery aneurysms, arterial septal aneurysms, conduction system disturbances, ventricular arrhythmias, endocarditis, endomyocardial fibrosis, mitral valve prolapse, intercardiac thrombosis, and valvular insufficiencies. GI involvement. Patients can present with abdominal pain, diarrhea, weight loss, and bleeding. This would be, if patients present with these symptoms, it would be very difficult to differentiate from an inflammatory bowel disease. So moving to diagnostic criteria, the diagnosis is basically clinical. The International Study Group for Behçet's disease adopted a diagnostic criteria. In the absence of other systemic diseases, Behçet's syndrome is diagnosed in patients with recurrent oral FA, which is at least 3 times in 1 year, plus 2 of the following: recurrent genital FA, eye lesions, skin lesions, or a pathology which is positive. The international criteria for Behçet's disease were developed in 2006, which included genital aphthosis, ocular lesions, and oral aphthosis. They give 2 points, And skin lesions, vascular lesions, neurologic manifestations, and pathology, 1 point each. And the diagnosis was made when a total of at least 4 points was achieved. Moving to management, so the goal of treatment is to promptly suppress inflammatory exacerbations and recurrences to prevent irreversible organ damage. So when multiple systems involved, multidisciplinary approach is necessary, and treatment choices should be individualized according to the patient. Mucocutaneous manifestations, oral LFT and genital LFT. Initial treatment would be topical corticosteroids. Then for prevention of recurrent oral and genital ulcers, we can give colchicine 1 to 2 milligram per day in divided doses. And when isolated oral LFT or genital ulcers are refractory to topical corticosteroids and colchicine, or when there are multiple lesions, we can start systemic glucocorticoids. The appropriate starting dose of prednisolone is 15 milligram per day. So for treatment of resistant oral ulcers, azathioprine had been shown to improve oral and genital ulceration, and TNF-alpha inhibitors, infliximab, adalimumab, etanercept, usually should be given in the combination of an DMARD like azathioprine to prevent formation of neutralizing antibodies. And also apremilast, cyclosporine, interferon alpha, thalidomide also have shown good results for recurrent resistant oral ulcers. So these are some studies and case reports. So moving to cutaneous lesions, usually all cutaneous manifestations except for erythema nodosum and pyoderma gangrenosum usually responds well to colchicine and low to moderate doses of glucocorticoids. However, erythema nodosum might need systemic glucocorticoids and other immunosuppressive like azathioprine. And as pyoderma gangrenosum can be complicated by the pathology phenomenon, it's discouraged to extensive debridement of pyoderma ulcers are discouraged in Behçet syndrome. Arthritis managed with colchicine 1 to 2 milligram daily in divided doses, and we can add low dose systemic corticosteroids if it's not controlled with colchicine. And resistant refractory arthritis can be managed with azathioprine, TNF-alpha inhibitors, interferon alpha or methotrexate. Ocular disease, usually anterior uveitis, can be managed with topical corticosteroids. If not controlled, might need short-term systemic glucocorticoids. However, posterior uveitis, which there is a very high threat to vision, we might need to treat with intensive immunosuppression with a combination of high-dose glucocorticoids and other immunosuppressives as like azathioprine. And refractory cases, again, TNF-alpha inhibitors has a place. GI disease, glucocorticoids and azathioprine combination, and we can add TNF-alpha inhibitors. And as in inflammatory bowel disease, there's a place for sulfasalazine and other aminosalicylate agents for managing GI disease. So vascular diseases, large artery involvement is uncommon but can lead to dilatation and aneurysm formation. So these complications might require combination of the medical and surgical or interventional radiology treatment. We can use high-dose glucocorticoids and immunosuppressive like cyclophosphamide as immunosuppression. And surgical interventions, it's ideal to perform interventions when the patient's disease is quiescent. However, It's necessary to intervene urgently if there is an enlarging or ruptured aneurysm or any organ-threatening ischemia. Venous thrombosis. So usually it results from endothelial inflammation, which leads to thrombosis. So the approach of to preventing venous thrombotic events in Behçet syndrome, control of the systemic inflammation rather than the institution of primary anticoagulation is recommended. So usually the treatment should include glucocorticoids in combination with another immunosuppressive agent. Again, neurologic disease depends on the severity and responsiveness of the to glucocorticoids. Azathioprine is commonly used as the first-line DMARD with alternatives including MMF, methotrexate, and cyclophosphamide. So the duration of therapy, it depends on the disease manifestations, and the treatment choices should be individualized, and severity of the organ involvement taken into account. However, in patients with severe manifestation, we will have to continue some sort of immunosuppression for at least 18 to 24 months. There are a lot of other therapeutic approaches which are under investigation, including biologics, IVIG, plasmapheresis, antibiotics, even hematopoietic stem cell transplantation. So prognosis of Behçet syndrome typically has a vaccine and waning course characterized by exacerbation and remissions. It's more severe in young male, especially in Middle Eastern or Far Eastern patients. The greatest morbidity and mortality outcomes are from neurologic, ocular, and large vessel arterial or venous disease. Mucocutaneous, articular, and ocular diseases are often worst in the early years of the disease, but central nervous system and large vessel disease, if they develop, may do so later in the disease course. So this brings to the end of my presentation. So the take-home messages: Behçet's disease is a recurrent and relapsing multisystem disorder, features both autoinflammation as well as autoimmunity. Genetic predisposition is known, and HLA-B51 is positive in around 50 to 80% patients. It's mainly a clinical diagnosis, not biopsy confirmed. ESR-CRP are usually high, but not always high, especially when there is no overt vasculitis. Treatment is with immunosuppressants and immunomodulators. So these are my references. So I would like to thank Dr. Gunendrika Kasturatna, consultant rheumatologist in NHSL, my trainer. Thank you, madam, for the guidance and support. And Dr. Janaka Akaravita, consultant dermatologist from NHSL, OMF unit NHSL, all my colleagues who involved in management of this patient as well as the patient. Thank you again.
Thank you, Mariam, for the illustrious case discussion. Time for comments and questions.
Thank you, Mariam, for excellent presentation. I agree with you. Sometimes oral ulcers can be very severe, and they may not respond adequately to low doses steroids, and sometimes they need TNF inhibitors. So we also had a patient like that, so not responding to other things. So we had to start TNF inhibitors initially to prevent recurrent severe oral ulceration, which results in dysphagia and difficulty in feeding. So other thing is methotrexate is not a choice when they have oral ulcers, because it destabilizes the mucous membranes. Azathioprine is the better choice in Behçet's actually. And other thing, sometimes this arthritis can present like septic arthritis with severe acute onset, severe pain and swelling. the most important thing is ocular presentation. Sometimes that can be asymptomatic. They may not have red eye, so nothing, no pain. They can just present with blurring of vision. So oral ulcer history also, that's a non-specific things. So most of our patients can have oral ulcers, and they usually contribute to like food. And so always you have to ask the history of genital ulcers. Sometimes they may have forgotten. So it may be there only at the beginning, the genital ulcers. So most of the time patients have forgotten also. Yes. So that history is very important to ask. Another thing is when they present with blurring of vision. So because it's not common, the diagnosis may be delayed. So whenever they present with that, so you have to look for retinal vasculitis. So retinal vasculitis presents with asymptomatic visual loss. So we have to start steroid, IV steroid in addition. So what the recommendation is, that EULA recommendation, I think it's like several years ago, what they to start steroids always with TNF inhibitors or interferon, not just oral steroids, not just steroids, if they have this retinal vasculitis. Otherwise, they can go blind. So early treatment is IV steroids plus TNF inhibitors or interferon alpha is a must. So, but it's like, so that's not time. So because we had about 3 or 4 patients. So sometimes when they present to us already blind. So young patient, that is very important to know. So other things, so they can have sometimes vasculitic ulcers in the lower limbs. So due to vasculitis, they can have ulcers, so recurrent ulcers, even in the leg ulcers, like recurrent. So not, yeah. So these are my comments, but it's a nice presentation. Thank you.
Congratulations, Mariam. We call the Behçet as variable vasculitis because it can affect arteries as well as vein, and it can affect small, medium and large vessels. That's why the name, now we classified that as a variable vasculitis. Other thing, I come across one of our patient, when they do the Mantu test, it became very significantly positive, 20 millimeter, and patient was treated for TB in another hospital. The underlying reason is pathology positive. Okay.
I just want to mention one of our patients, actually it was present in grand rounds. So that patient had extensive thrombosis, inferior vena cava, and even right atrial thrombosis, and patient was collapsed on admission, and actually ICU team have refused to resuscitate also. Some MOs have refused because it was like, and that patient was treated with initially IV cyclophosphamide and TNF inhibitors, and I like to say that that patient is he's from the Eastern Province, and now he's a medical student at Uvavelas medical faculty. Okay.
Thank you, and thank you for the interactive discussion. Yeah, that brings us to the end of CME for February. Please join us in March also on the 6th, because February has 28 days. It falls on the 6th of March. Thank you.